Okay, so thank you all for joining us this morning, and it's great to see so many people on a Monday morning, so eager to learn about the impact of substance use during pregnancy. So my name's Francesca Shearer, and I am the Quality and Governance Manager for Turning Point Substance Misuse Service, and I'm also the Pregnancy Lead. And then with me today, going through this session, we've got Angela Geraghty, who will be joining us in a minute, and Sarah Stone, who are our specialist midwives for substance misuse and vulnerability. They cover all of the UHL hospitals, but are based at the LRI. So in today's session, why is it not moving? Give me a mo. There we go. The objectives of our training session today are to explore why women who use substances present late for pregnancy care, substances and the impacts on the developing baby, fetal alcohol spectrum disorder, the treatment pathways for women who use substances during pregnancy, neonatal abstinence syndrome, so this is post-birth, sudden infant death syndrome, again post-birth, and how we as professionals can better support women who use substances both during pregnancy and after birth. So before we get on with the content of the session, what I wanted to do is just, if we could just type in the chat what agency you work with and what your job role is within that agency, just so we can get a bit of a feel of who's in the room and kind of where we're pitching this session to.
I will take the attendance based on that. Thank you.
Fabulous. So we've got a real range of people. I know that probably not everybody's written their answer yet, but we've got a real range of people. So we've got people coming from LPT, Family and Wellbeing Service, social care, health visitors, public health, Turning Point. So we've got quite a range of people in the room today. So hopefully where we're pitching this, it will help social workers in your assessments and maybe your understanding around the substances that are used during pregnancy, and kind of getting a bit of a grips with sort of what we do both at Turning Point and also via antenatal care with the midwives as well. Right, let me go back to my screen. Okay, so I will hand over to Sarah to go over the next slides. Let me know when you want me to change the slide, Sarah.
Yeah, sure. So why do women who use substances present late for antenatal care? Well, a lot of women don't realise that they're pregnant. They are not in a position, most of the service users, well, a lot of the service users that we have don't actually, they're not in touch with their health and well-being. So they probably wouldn't fully be aware of when the last period was and might think, oh, it was the last time a long time ago or not. Some might not have periods, some might be sex working and they're just, you know, it's just all over the place. Some think that they can't have children because they've either been told that or they've used drugs and not managed to get pregnant in many years, and all of a sudden it happens. There's also a disbelief when people do know, so they're in denial, especially if they've had babies removed before, because they obviously know what kind of route they're going to have to go down. Also, I think that women that get pregnant whilst they're using drugs, they kind of try to come off the drugs before they engage with health, so that the involvement of social care is hopefully not going to happen. Unfortunately, that doesn't work. And some try to just simply conceal their baby because they want to hang on to it for as long as they can. And as we know, every day is a new day, and every day they mean to do better, but often can't. And as it says there, the physical symptoms, nausea and vomiting, is often mistaken for withdrawal, so people just don't realise, and then we get really late bookings, and those things in themselves have a great risk. It's not that if somebody books early, hopefully we can engage with them and get them on a programs where we can where we can stop them from continuing to take drugs. But if not, it's about that engagement anyway with health. There's a lot of shame, guilt, stigma, lack of trust, fear of the consequences, as we've said, the previous experiences. For instance, we've just had a lady that only delivered in December last year, and then she's just delivered again prematurely. So unwanted pregnancies. Some people use termination as a contraception, really, and but often when they find out they're pregnant, they're too late. So I think that's why they present late. But as early as we can get people in, that's that's the main aim, really. Yeah, we should be routinely discussing the possibility of pregnancy, and I think we're really quite good at that, especially in teamwork with Turning Point, and also with the sex worker support officers and all the other agencies that we work with. They're very good in talking to the women on the street about that, so that they are the best people really to pick it up and get it to us. So as soon as you find out that a service user is pregnant, whether or not they say they've booked with the midwife, the best thing is just to complete a referral form and send it in to us, and then we can look at that, and that's promoting the best safety for mum and baby, really. Yeah, so we all know why people take drugs. It's from past trauma, it's from habit and learned behaviour, tragedies that have happened in people's lives, and many other reasons. But in pregnancy, the reason does matter why, but in pregnancy, what we want to do is identify as soon as possible about the pregnancy. All the rest can be dealt with later on, so we can deal with all the reasons and everything, but I think it's just crucial to let us know about it. The service users,
just on that point, it is about letting the midwives know about the pregnancy, and then it's the role of Turning Point as well to support with the social conditions and things like that, where we work in a multi-agency way to look at all of the other factors that can kind of impact on that pregnancy and impact on that person's substance use as well.
Yeah, absolutely. And I think the work that we do together is absolutely crucial. And with the police and all the other agencies, all of you, your work is absolutely invaluable. As Fran just said, the service users are often impacted by the adverse social conditions, poverty, poor nutrition, homelessness, all of that. And all of that has an impact on pregnancies and on babies as well. So the sooner we can get to people, the better. So when you do a referral to us, it's well worth making that consideration, what other agencies need to be involved, and as soon as possible. And if you're ever unsure, just give us a call and we can always give you that support and go through it with you. It's not a problem. Just go on to next, please. Thank you. Right, okay. So women that use substances, they will always minimise the use of the substances. They will always say, well, I've had a baby before, but you know, and that one was all right, because they don't actually understand the implications. One, because perhaps they haven't parented. Two, they may not know the signs of a true healthy and really, you know, well child. And also, I think a lot of the time they're in denial because they want to carry on with their use. So they'll minimise it to make themselves feel better as well, because of the guilt and the shame and everything else that we were saying before. So substance misuse is associated with increased rates of mortality. So women will carry on because of that denial, taking the drugs through pregnancy, and they're at very high risk of stillbirth, miscarriage, hemorrhage for themselves. You know, and we have had mums and babies die, and that's why it's absolutely crucial that as soon as we can get some care in place, the better. We all know that substance misuse can affect the growth of babies. It can cause many different things, and some that we're not aware of. So you have all of the development issues. Some of these issues might not even become apparent until the child is developed quite late on in life. So substance misuse is linked with depression, for instance, in teenage years, but we wouldn't necessarily know that early on, although we are getting better at recognising poorly mental health in children. It's very difficult to evidence these things, but there most certainly will be some developmental delays, behavioural challenges, if not structural and physiological damage. So also we're having women more and more come through with liver damage from alcohol use. So that's a story all on its own. And I think as well, women that are going through detox or withdrawals, trying to detox themselves using street methadone instead of the safely prescribed version that we give. So I think that there's an awful lot in there. I know I'm going over the top of a lot of things because the detail is just massive. But I think that, you know, if they're withdrawing, there's going to be some major issues as well. So we try to get women into detox if we can, and hopefully try and get them from misusing substances so that the baby won't suffer so much after the birth. And also for the woman's well-being, obviously, ultimately, we want the women being well, and we want to teach them, and that education is so crucial. Get the education around the substance misuse, give them some guidance about lifestyle, give them some outlook about their lives. They've probably never had all that guidance and love, and, you know, shown that anybody cares about them. So it's really important, again, all that work that we do. Morning, Ange. But different levels of intoxication and withdrawal means that the fetus will experience these too, and that really is a hostile environment for babies to grow in. Even smoking, right down to, you know, just smoking cigarettes, that is a hostile environment for the baby. And I have got a favourite picture that I like to show, but I haven't put it on here, and I wish I had. I once saw a video of, yes, it was a video of a mum taking a puff of a cigarette, and as she took the drag of the cigarette, they were scanning inside, and the baby, you could see in the water the changes in the baby was rubbing its eyes. So that's stuck with me for many years. So yeah, it is important for us to use professional curiosity about substance misuse and be aware of the risk of disguised compliance, because we get a lot of referrals that say oh, crack cocaine before pregnancy, alcohol before pregnancy. Was it just before? Was it a year before? Was it 10 years before? That information is really crucial, because when Angela and I come to see the women in our substance misuse clinic, they're referred to us from the community midwife if there's any alcohol use within the last year between 14 and 20 units per week. So they are referred to us because that on its own could have an impact. And, you know, when did they find out they were pregnant? Is it a late booking and they've stopped before pregnancy, but now they're already 18 weeks? So we need to try and get to them as soon as possible and just do that referral.
And just to chip in just about the disguised compliance side of things and professional curiosity, I think in all of our roles, that's something that's incredibly important because of the feelings. So it's not that somebody is just wanting to deceive for no reason. There is such a level of shame, there's guilt, and there's a real fear of the consequences, because the consequences of not stopping your substance use in pregnancy are huge for these women. So we need to be really, like, always have an open mind, and it's respectful uncertainty and not being overly optimistic. If somebody tells you, I've stopped drinking, just bear in mind that, because we often get it from other services, they'll say, yeah, but they've stopped drinking. But how do you know that? Because our toxicology screens don't tell us that for sure. And we need to be working with evidence. So although we want to be optimistic for people, and we believe in change, we want people to do well, we want these pregnancies to go well, we just have to be mindful that what is being said might be underreporting, and it might be more what the woman wishes or wanted to have happened that week, that month with their substance use. And people will go to great lengths to disguise compliance. We often get people who will falsify their urine screens, and the only way we kind of detect where that has been done, they can water them down. So sometimes that will show on the midwife screenings that the urine was dilute, so they might have watered it down, which will then potentially give a false negative. But we've also had somebody recently who their use was cynical, in the sense that they started to use drugs that they knew turning point tests didn't test for. So they started using things like MDMA and ketamine, which our tests don't show for. But actually the midwives' tests that are much more detailed picked up on those things. And then that's how, as a service, we were able to realise that sort of there was other drug use going on, and this person wasn't abstinent as they were saying they were. So it's just about being really always open-minded, respectfully uncertain, but continuing to be optimistic and supportive of that person as well. So it is a really challenging balance to strike.
Yeah, definitely. And I think as well, every single woman when they get pregnant, they do absolutely love their baby and they want the best for it. And I do truly believe that when they say they want to stop, especially in pregnancy, I do believe that. But there's all the other reasons why they don't. So I think that's worth bearing in mind as well. I think it's about stripping back the layers and getting to know that person and how to reach them in order to be able to, work from the inside out, really. I think we probably work from the inside out and you work from the outside in at Turning Point, which, hopefully we'll meet in the middle and have a good result. But yeah, our tests, unfortunately, it's very difficult when it comes to the dilute urines, because yes, they can have water in, but it also depends on the metabolism, their BMI, whether or not they're very well hydrated. Because we have had quite a few women in that are abstinent from drugs and alcohol, and that's been shown by other means, but their urine is dilute, and it's because they're well and looking after themselves and they're well hydrated. So it's a really fine line. But in the absence of any other facts, I think that's worth considering. But if there are any, if there's any suspicion, and that the person hasn't been doing well and following the drugs treatment and recovery program, then that's a sign of disguised compliance at that point. So I think Angela's going to do the alcohol. Is she
Oh,
there?
hi,
Yeah.
yes, I'm here. Thank you. Sorry about that. Slight delay on getting back. So alcohol in pregnancy. There is no safe limit of alcohol. We do say that high alcohol is a high risk to the pregnancy, low alcohol is still a low risk to that pregnancy. And the only best thing to do is no alcohol, because then there is absolutely no risk to that pregnancy of that baby getting fetal alcohol spectrum disorder. So we also discuss it, as Sarah said earlier, we want to know when they last used alcohol. So we look at people who use above 14 units, because we know that if somebody's been drinking more than 14 units a week, then they're a regular user of alcohol, usually at the weekend. So we like to explore that when they use the alcohol. Are they having alcohol for 3 days? How much they're using in one go? A lot of women don't realise that a large glass of wine could be more than 4 units, and we have research to show that as little as 4 units can impact on a baby. We also know that from 4 to 5 weeks is when a baby becomes vulnerable to alcohol, and that's during the embryonic stage of development, when brain cells are starting to develop and major organs are starting to develop. So having alcohol, it is a toxin. It does pass straight across that placenta to the baby, and babies can't metabolize it. They don't have the liver to do that. They don't have the blood filtration system to be able to get rid of the alcohol. So it can cause a buildup of that toxin as that baby grows, and can cause neurodiversity in that baby, which can't be shown. We can't identify in pregnancy if that baby's been affected, or very rarely can we. I think in all the time I've been a specialist midwife, we've had one baby that was diagnosed as likely to have significant fetal alcohol syndrome, and that was due to a brain scan in pregnancy. But generally speaking, you can't tell. So unless it's impacted on the development of major organs, and then you might have some inclination. They might have a larger liver, they might have an issue with the kidneys, they might even have some other additional issues that we can identify. So the fetus, as I said, can't filter out the toxins, which then causes significant damage to brain cells, the nervous system, and the other organs. The frontal lobes, which control critical thinking, reasoning, and judgment, are particularly vulnerable. And that's why when we have FAS, a lot of it is down to neurodiversity, autistic spectrum disorder, where somebody is on that line, but it could be quite mild to quite severe. But we aren't going to know that until that child starts to grow and develop and reach their milestones following birth. Oh, you've gone. I didn't see you click that one. So, like I said, even small amounts of alcohol influence fetal behaviour. We don't know. We know in the first trimester, so that's the first 12 to 13 weeks of pregnancy, is when the baby does the majority of their development. After that, it's about growing and maturing their organs. So we know in that first trimester, it can have massive impact, but it can also continue to impact that baby throughout the pregnancy. And it can impact on the baby in utero, rapidly decreasing in fetal breathing and movements within that fetus inside the uterus. Alcohol can, as I said, cause fetal alcohol spectrum disorder. It can also cause miscarriage. It can cause slow fetal growth. So we often get small for gestational age babies. It affects the placental function, which means that we can have premature babies, we can have congenital abnormalities. we can have stillbirths and babies with quite low birth weights that start to drop off on the trajectory, and therefore we have to often induce or bring that delivery forward to try and prevent any stillbirth. It also increases the risk of sudden infant death syndrome after the birth. If you've got a dependent alcohol user who's pregnant, we often say you shouldn't stop alcohol suddenly, as that quick withdrawal can cause fitting and can lead to maternal death and that of the baby. So we often say that it needs to be reduced slowly and safely, and ideally in a detox unit where we can monitor it carefully. Often brief interventions when you first see that lady is the best way to go. I've done that on a few occasions with women that have been alcohol dependent. I've advised them to use it like a medicine and try and give themselves a small amount every hour, and also save some in them for the middle of the night until you can get them into that detox unit. So as you can see here, fetal alcohol spectrum disorder on a baby does have those facial characteristics, and these occur due to the alcohol that's in the first trimester. So we often have these lines of we've got a philtrum here, and often with the babies with fetal alcohol syndrome, they will have quite a smooth philtrum. So it's absolutely quite there's nothing there. It's very smooth. They also have a very, very thin lip, upper lip, and that's quite noticeable when you actually look for it. They might have quite small little eyes and a broad bridge of the nose, and they sometimes have these sort of little double lines, train tracks on their eyes. So
The ears are usually quite low set as
they
well,
are,
aren't they?
yeah.
Yeah, and I think alcohol as well, you know, you just the withdrawal's evil. When you see a baby withdrawing from alcohol, it's really, really quite awful.
It
So the
is.
more we can do to help the service users to stop having alcohol, the better.
Ladies,
And
can
it-
I just ask what actually causes? I mean, I know it's the alcohol that causes it, but how does it actually do that? What is the sort of scientific reason for those facial disorganizations, if you like?
As it alters the cells and it alters the way DNA can act and chromosomes. It can affect chromosomes, and it can affect the I don't know the word for it, the cell. Help me out, Ange. I've got menopause.
It's when yeah, it's actually when in that first 12 13 weeks, so the facial characteristics are very prominent in the first 12 to 13 weeks when alcohol's used, and that is because the baby's features are starting to develop. Everything is starting to develop in those early days, and that's
The
when
alcohol
the
interferes
alcohol,
with that.
yeah, it's a toxin. It can't be metabolized, so it's in the system and it goes through all the system, all of the blood vessels, and they are what interact with the development and the growth of every organ. So it's the cell division, so it just impacts massively, and we know that this specifically interacts with various cells and various organs, particularly around the nervous system. So it's all part of the nervous system. And that's why we get quite a lot of neurodiversity and we get these facial features.
Wow, thank you.
So moving on to benzodiazepines. Well, we know benzodiazepines cross the placenta and can affect the unborn, especially if they're high doses in the first trimester, again, around the development stage of the fetus. And it can have significant impact around cleft lip and cleft palate and hair lip. So we can find that can be a consequence of significantly high benzodiazepine use. We also know that anybody that's having alcohol treatment and goes into alcohol treatment, we often use benzodiazepines, but it's looking at what's safer, what's the less riskier. We can treat hair, lip and cleft palate. We can't treat fetal alcohol spectrum disorder. Once the baby's got it, we can't change it. It's for life. So with benzodiazepines, it is something that we can do if a baby is affected. So symptoms of benzodiazepine toxicity in newborn often makes them quite sedated. They have less muscle tone, which means they're quite floppy, and they have quite significant breathing difficulties. So when they come out, they may not gasp, they come out quite pale and might need support with breathing initially. It can cause fetal and neonatal respiratory distress, so it does stay in the body quite a long time, more so, and we often say that a baby withdrawing from benzodiazepines will have, if a mum's using heroin and crack and benzos, the baby may go through that initial withdrawal and start to just come out of that withdrawal, but then by day 10 to 14, they take a downward turn, and that's often the benzodiazepines withdrawing because of the longer half-life that they have. It can cause
also cause
again,
feeding problems, can't it? So,
absolutely, yeah.
you know, because the baby's quite sedated, if you like, causes feeding problems. The baby can then lose weight and consequently will possibly have respiratory distress and breathing problems. So there's a higher risk of admission to the neonatal unit for intervention and treatment. So
Yeah.
it's just a downward spiral really for the baby.
They often end up having a preterm birth, which in itself can cause breathing problems, because we know babies produce surfactant when they give birth, and that's sort of after 34 weeks. And we often, if we have a premature a mum coming in preterm labour, we may want to give them some steroids to try and help produce the surfactant so that they don't suffer from respiratory issues. But again, it depends on if we can give them that treatment prior to the birth. They often will have low birth weight. They can't always regulate their temperature, and they can also, like I said, have the fetal abnormalities such as cleft lip and palate. NAS can also be part of that, and an increased risk of sudden infant death. The pregnant person should not cease these medications, and we should be referring, if we've got somebody who's addicted to prescribed benzodiazepines, then we should be referring them through to Turning Point so that they can have a close management plan about a gentle reduction. We know in Leicestershire, we try and get somebody below, ideally 15 milligrams or even 10 milligrams a day at the time of delivery if they want to breastfeed. They can breastfeed on that amount, but certainly not on high doses, because that does go through to in the breast milk, and it will cause toxicity in the baby, and again cause that baby to be very sleepy and drowsy, resulting in them poor feeding, resulting in poor weight gain, and potentially in those early days that will cause them to have jaundice, and these babies might have to have light treatment as a consequence of that.
I think as well, you know, mums that use benzodiazepines, if they are breastfeeding, they don't often exclusively breastfeed, and therefore that means that they're on it, they're off it, they're on it, they're off it, and the baby can just continue to withdraw. So it's not really fair for the baby to continue to breastfeed if the mum's not going to do it exclusively.
Yeah, they need to have that regularity of breast milk to help the natural detox in any any treatment program, if you've got a baby that's withdrawing from any sort of substances, ideally, if they're breastfeeding, we want them to exclusively breastfeed with maybe a bit of a top up at the end of the breastfeed, but not to alternate.
And as long as you know that there aren't any other drugs that are being used.
Absolutely. So I will hand over to the next slide to Sarah. And she's going to talk on tobacco.
There's
Yeah.
a hands up.
Do we want to take questions as we go along, or do you want them? Is that all right?
Don't mind, yeah?
Yeah. Okay. So is it Berman?
Yep. Yeah, I think that was quite useful. I think about the benzos, and I was just going to add in terms of, particularly there's a study that was carried out for people who were given Librium or chlordiazepoxide for detoxing from alcohol, and the Medicines Health Regulations Authority now recommends that we should give people advice who have been detoxed from the time they finish their detox. They need to use contraception for the next 7 months, because those sort of genotoxic or teratogenic effects could be passed on to the young ones.
Definitely. That's good.
Fran,
Okay,
what
so
do they tend to, sorry, Fran,
It's
what do
fine.
they tend to use at the level? Is it benzodiazepines these days?
Yeah.
Because
yeah.
yeah,
As far as I'm aware, it's the same, and then the women are just informed of obviously the risks.
Yeah.
But it's, as you said earlier, the risk is greater from alcohol than it is from the benzos, isn't it? And actually, it's administered in a very controlled way, and they are obviously reduced from them gradually. There's a specific program. We're going to talk about detox in a little bit more detail later, but they are in a controlled environment. There are doctors there that are monitoring that administration as well. So it's slightly different to somebody who is using them illicitly or somebody who is overusing a prescribed medication.
Yeah, thank you.
Okay. So we're much better at trying to help people who are trying to stop smoking now, and within our services we've got the Quit Ready, and the National Stop Smoking Services, which have been successful in many ways. However, with our service users, it's quite difficult to get them to stop smoking, because that is their crutch after they've stopped using the substances. And if we weigh up both of them, which would we rather? Not that tobacco smoke's any less dangerous. It's just, it's not illegal, and also I think it's probably, would I say, easier to stop smoking or to reduce smoking than it is drugs. So although I'm fully aware of all of the dangers of smoking, and absolutely we should always try and help to reduce the use of tobacco, especially with other drugs, and such as crack, cannabis, and anything else, because that's the baby having a double whammy there with 2 lots of toxins, and then they've got toxins in, there's thousands, hundreds of toxins in cigarette smoke. What happens when a mum takes a puff of the cigarette is it restricts the oxygen supply to the baby, so it narrows the vessels that carry oxygen from the mum, because the mum is the baby's oxygen supply, so that narrows the vessels. So if you see a placenta of a mum that doesn't smoke, it's usually nice and meaty and fleshy, looks really healthy, nice thick cord, bouncy. It's well hydrated as well. If you see the placenta of a smoking mum, they're often quite flat, round but flat, and they have little areas of calcified, so hard white areas, which means the placenta is shut off and died in that area, and the cord's quite stringy and thin, and that has really reduced the amount of oxygen that baby can have, and therefore that will impact massively on the baby's growth. So as I said, it's difficult when when somebody's smoking, and there's other substances as well. But you know, smoking is one of the most well-known substances that you can use, that it has the greatest impact on fetal growth. So, I mean, that's a tough choice, isn't it? If it's going to be one or the other, which one will it be? Hopefully all, but we do need to still target tobacco use. But I understand it is difficult amongst our service users. There's a massive risk of sudden infant death syndrome, as we know, because of all the facts that we know about that causes sudden infant death syndrome, miscarriage, preterm birth, and you know, many other aspects of poor health. Secondhand smoke is no better. What I've started to do, well, I've been doing it for quite some time really, is speak to our women about the smells and other impacts, the social impact to the child as well and to them. For instance, I would say when I'm going through reduction, I would say, you know, when your child is growing up, just thinking ahead, what would you like your child to remember you from? The smell of your perfume? Or do you want to smell cannabis or cigarette smoke and say that reminds me of my mum? And most women are actually horrified, and I have had a few service users that have said that really had a big impact on me and it's made me stop smoking. I'm not saying that's, you know, but what I'm saying is I think things like that are more real really have an impact, because everybody knows that smell. And I would say, would you like your baby to be smelling of smoke or to be smelling nice? And they'll go, no, no way. So I think those realities, it's worth bringing those up as well. But I think it's essential that the women do have all of those risks above really need to be stressed to them. And as I say, I've got a brilliant picture. I can share that with you later, Fran, and if you want to send it out, it's quite impactful. It usually has a horrible effect on the women, and they're like, oh no, when I explain what it is. So, okay, so is this you, Ange, or me?
We have another hands up from Kelly Walker.
Thank you. Just a quick question, and it may well be coming up, but I'm looking at the impact of vaping as well. I'm assuming it's similar to smoking, or there's not as much research. So I just wanted to ask about the impact of vaping on baby.
Yeah, it's unknown. But what we do know is that vaping, although it's likely, I think, to come out, I'm sure we all know that, you know, there will be impacts shown, but it's unmeasured at the moment. But we all know that the toxins of tobacco are probably way more dangerous, and because of the amounts of different toxins there are in tobacco smoke, that vaping would be preferable. We don't know is the actual honest answer. We just know that it's safer than tobacco smoke.
There's another hand up from Berman. Is that a legacy one?
Yeah, that's just a question that just popped up in my head when you mentioned, I think, about the tobacco and how it sort of affects the placenta care of vasoconstriction. Have you come across, I'm just interested in, have you come across during your practice, particularly with women who have a caffeine addiction, because it has a similar vasoconstriction effect as well that can lead, you know, shortening the blood supply to the fetus. Have you come across any? Yeah,
it's difficult to attribute it just to the use of caffeine, and often caffeine and tobacco go hand in hand, so it will be difficult to separate that. I don't do the investigations of placentas. I've delivered many babies, obviously, with mums that do use caffeine and tobacco, but I wouldn't be able to attribute it, so I couldn't say, to be honest.
yeah, that's helpful. Thank you.
Okay, so we know that opiates pass across the placenta, and I think many of these drugs go hand in hand, really. as in respect of the effects on the fetus and disruption to the baby's physical and cognitive development. It can also have an impact on preeclampsia. I wouldn't say cause it, but it can have an impact on that because it can alter blood pressure. Usually it does actually lower blood pressure, which is, you know, a contradiction to preeclampsia. So I don't really know why that's in there. It does have an effect on it, but I wouldn't say it'll cause it. They can cause miscarriage. They can cause developmental delays. Obviously, it's impairment of the mother, which may help her, make her have really risky behaviour, messing with the wrong people, associates, and that in turn could lead to other drug use as well as opiates, and putting the baby in danger. And as we know, stressful environments, domestic abuse, and all the rest of it as well that comes with opiate use can actually impact on the fetus as well. Yeah, it can cause fetal convulsions, both in utero and when the baby's been born. The fetal growth is affected by every single drug that we can talk about, which babies that are growth restricted have their own problems, mainly with being able to maintain their blood sugar, which means they can't maintain their temperature, which means that they will have respiratory distress. Mums can give birth very rapidly, and that can be caused by placental abruption, or it can they just have precipitate labours. The baby's just born like that, and then the uterus doesn't have time to contract, and therefore the mother will hemorrhage, and it can be life-threatening, and it can be actually fatal. So, you know, when there is a placental abruption, the placenta shears off from the uterus wall. That cuts off the oxygen supply to the baby. If the baby's not born immediately and get help, the baby will die. And as I said, mum will hemorrhage as well. So, you know, it's really, really massive. The impact is massive. The withdrawal effects for babies after birth, it's quite horrible to see because they don't get treatment. Literally, they're just watched, and it doesn't always happen within the 24 hours, which is why we usually keep mums and babies in the hospital after birth if there's no opiate use for 24 to 72 hours to monitor the baby, and then mum's allowed to stay with the baby. So it can be crying, it's a high-pitched cry. There can be jitteriness, excessive feeding or really poor feeding, which again would lead to temperature loss and respiratory distress. And then also there's the irritability, seizures. Some babies, in fact, there was a few months ago, there was a baby, wasn't there, Ange, where we pick the baby up. You don't see a newborn baby with the limbs like straight down like that. They're always, the legs are up, knees bent. This baby picked it up. The legs were straight down like that. The body was rigid. And that baby is really, really suffering. They also can excoriate, which is excessive opening of the bowels, which is acidic because of the substance misuse, and that strips the baby's bottom, which can expose the skin. You know, it can expose it really, really badly, peels the skin off, and it's almost like pressure sores. Really, it kind of has that kind of a look, and it can be bleeding. It can get infected. The baby really, really suffers with that. Vomiting. Baby wants to feed all the while, so there's an excessive intake, fractiousness. The baby was sleeping, will sleep, then all of a sudden wake up 20 minutes later, half an hour later, consume a whole formula feed, and then vomit the lot up because really it doesn't need it, but that's the only thing we can use to support the baby, really. We often use dummies for those babies. So as it says there as well, children exposed to heroin in the womb are more likely to have behavioural issues, difficulties with concentration and attention, hyperactivity, aggressiveness, and a lack of social inhibition. They're also likely, if they continue to be exposed to that behaviour by parents or people around them, to adopt that behaviour themselves. And we see that happen quite a lot with our service users. So that's why I'm very against mothers using heroin going home with their babies, which has happened not long ago. So it's a hard thing to deal with. Ange?
Hi, thank you. So stimulants, so we're looking at anything from cocaine, crack, MCAT, amphetamine, ketamine, MDMA, any sort of stimulant that a mum has. It passes through the placenta and enters the baby's circulation. It takes much more time for fetuses to eliminate this from their bodies. They do struggle. It has to go through their livers and then through to the kidneys to be excreted, and they do struggle with that. The effects, the developing neural system, so any part of the nervous system will be impacted by stimulant use, and can cause vascular constriction. So it restricts the blood flow through, decreasing the placental blood flow, and can cause inadequate oxygenation. So by it reducing that blood flow, there's less oxygenated blood going through to the baby, and that's the issue that we have. And it also reduces, like Sarah said about the placenta earlier, it can cause some of that placenta to die off. So that reduced blood flow increases the risk of miscarriage, placental abruption, and that's where the placenta comes away from the wall of the uterus and causes significant bleeding. And it can, if somebody has a placental abruption, a massive placental abruption out in the community, it can cause death to both mum and baby. If they have a placental abruption, they can have a rapid birth, and that can be quite premature, and then the mum can bleed out quite significantly, and they can lose an awful lot of, they can lose their whole volume of blood within 5 to 10 minutes. So they need to be able to access urgent medical care. So like I say, it's life-threatening to both mum and baby. And, you know, we did have somebody that happened to last year. So it's quite important to remember this does happen. And I think a lot of the time we talk about these things and people always think, oh, it won't happen to them, it won't happen to them. But it has happened. And
it does happen,
horrific.
yeah, a lot.
So we often get slowed fetal growth because of that. We know that the blood flow is producing all the nutrients as well as the oxygen for the baby to grow. And as such, if that is impacted, then it's going to be reduced. We have an increase in blood pressure because you've got that constriction in the blood vessels and in the vascular system. That will increase the blood pressure because then it has to increase to push that blood through. It can cause preeclampsia, premature labour, low birth weight, birth defects, neonatal abstinence and SIDS, and developmental and behavioural issues in later life, and impact on cognitive performance. So we are looking at children with neurodiversity with stimulant use. Mothers should be advised to cease use immediately. With regards to cocaine users, where it's where they're snorting and they're using it occasionally, they can stop. They can stop instantly. It's not going to make a blind bit of difference. However, crack users do struggle because they are quite dependent. So we do need a lot more input with them to try and help them reduce that crack use.
I think it's important to stress as well that when service users, pregnant service users, are coming towards the end of their pregnancy, or I would say any time over 30 weeks especially, you could reiterate at Turning Point, it would really be helpful if you could reiterate, you know, baby's movements. I'm sure that you do anyway, but you know, any concern about baby's movements, they need to come in and get monitored, or speak to us at least, so that we can convince them to come in and arrange to get them in for monitoring. And it's important that any signs of labour at all, that they contact the hospital and come in, or even if they come in, just come in, which is not ideal, but it's better than just doing it alone in the community. So I think, you know, a lot of people that do use cocaine, especially, and crack, you know, we've had quite a few deliveries in the community, and really that's not it's not safe. So we want to get people in as soon as possible.
Yeah, absolutely. And then moving on to cannabis. So Sarah's already spoken about smoking. With cannabis, it has that increased risk. It has obviously the THC as well as the cannabis part of the drug that people find beneficial, and it's the THC that causes the mind altering, what's the word? It's gone out of my head. It'll come to me in a minute. So
Congenital abnormalities.
no, it wasn't that thing I was thinking of. Hallucinating effects. So the THC causes the hallucinating effects within the cannabis. And people don't often realise that cannabis is a hallucinogenic drug, but it is, because it does alter our mind and how we perceive things. It's associated with the reduction in oxygen and nutrition to the placenta, and that's because it has increased carbon monoxide. It actually has 5 times as much carbon monoxide as smoking a cigarette. So that's massive. And we do smoking carbon monoxide levels on women, and we should be doing it at every contact, and we can tell the difference. Smokers will often be up to sort of 20, especially if they've recently used, but we can tell that, you know, if somebody's a cannabis smoker, they can often be a lot more than that. So it causes growth restriction, impacts on the nervous system and the development, and we have had some research show it is linked to neurodiversity as well, and ADHD and autistic type behaviour. It can increase the risk of preterm labour and low birth weight. I do apologise for the additional speaking I've got in the background. It's my grandson who I've got. He's just here. He's not a happy boy. He's not a happy boy. So it's linked to stunted growth, ADHD, anxiety and depression, reduced attention and executive functioning skills, poor academic achievement, and more behavioural problems in later life due to the impact the THC has on the baby's developing brain. And, you know, we often say that a lot of them say, oh, you know, my parents used it. Well, back in the 60s, it was probably more natural. It wasn't chemically enhanced as it is today. And I think it's that increased chemical influence that has increased the concerns that we have with cannabis use. It also has 3 times as much tar, so it has a bigger impact on these women, and these women do smoke a lot, so they're more likely to get respiratory issues and COPD as they get on it, which is COPD. Brain's
Chronic
gone.
obstructive pulmonary disorder.
Thank you. My brain's
which affects
really...
the lungs basically, and if you combine that with crack use as well, basically our service users are at a much increased risk of that.
Absolutely.
And with tobacco.
Yeah.
Along with, yeah. So it is quite significant. We do try and persuade them to get referred to our smoking cessation, because they can support with the reduction in cannabis as well as the reduction in smoking. I often say to the women, as at the very least to start off with, put a filter in. They will often use roach, which is just rolled cardboard to prevent the end getting soggy. But then we recommend putting filters because it's not going to impact on the amount of cannabis that they get. It just filters out some of those impurities. Moving on to Fran,
Oh,
who's going to
thank
talk
you.
about treatment pathways.
Lovely. Okay, so as Sarah touched on earlier, where we recognise that somebody is using opiates, so that might be heroin, or it might be that they are using over-the-counter medications, things like cocodamol, or they might be misusing prescribed medications, things like codeine, tramadol, fentanyl.
Oromorph.
Yeah, all of those kinds of things we can support with, basically. And it's really important that we know as early as possible in the pregnancy, so we can kind of get them on the right treatment program. So we use, at Turning Point, we use opiate substitute medication to support our women. So they are things you'll hear talked about: methadone, phyceptone, and something called Espranor. So it's important that we use opiate substitute medication to enhance the stability of these women during pregnancy. It is safer to be prescribed medication like methadone than it is just to give up opiates suddenly and experience withdrawals, because, as Ange and Sarah have said previously, it causes distress to the fetus and we're increasing the risk of miscarriage and stillbirth. So it's more important that we get a woman on a dose of opiate substitute medication, and we titrate them up onto a dose that supports them. So we do that gradually to support them to get on a dose that means that they don't feel the need to use substances, that they're not experiencing any withdrawals. Sometimes there can be a misconception in the community and other services that a high dose of methadone would be risky. But actually, what we know is a mother who is on a high dose of methadone and is not using on top is a much safer parent than somebody who is on a low dose of methadone but then is actually using on top. So it's not always about getting people off methadone, reducing methadone, things like that. Actually, if they're on a stable dose, that is what we like to see. And during pregnancy, we really encourage stability over sort of reductions. So I'll talk about reductions in a minute. But if a service user is already prescribed Espranor, which is what we prescribe, but buprenorphine is something you might have also heard it called. It's just that buprenorphine is a different type of the same medication. So Espranor is a wafer and buprenorphine is a tablet. If they are already prescribed that before they become pregnant, then we can continue them on that medication. However, they should never ever be started on an Espranor prescription, because they are required to be in precipitated withdrawals when they start the medication. So they would be basically withdrawing to start that medication, and we know that any withdrawals would be felt by the unborn and would be kind of increasing the risk of fetal distress and miscarriage. So if somebody is already on Espranor, it's really important that we're talking to them about that risk, and that we make sure that they know it's important that they collect all of their doses from the pharmacy and that they don't miss a dose. Because if they start missing doses and then they fell off of their prescription, Espranor would not be an option, and that they would only be able to be restarted on basically methadone. We advise that kind of once somebody's stable, that we don't make any reductions to that opiate substitute medication in the first first 12 weeks of pregnancy. And it's important to avoid stopping substitute treatment rapidly and abruptly, because it can lead to miscarriage and premature birth. So we can do reductions in the second trimester, but actually they'd need to be very slow, very monitored, and we tend to be err on the side of caution, because if a woman is reducing, that actually can increase her risk of relapse. So we just like to try and make sure that somebody is incredibly stable before we start thinking about any reductions, because it's not always the right decision to make for that woman. So we just need to be mindful of that. And as professionals, if you're kind of in another area, you're not in substance misuse treatment, it's encouraging that woman's stability over anything else, and being reassured that a woman on an opiate substitute program who is compliant with that is kind of got better chances within her pregnancy, and after the baby is born is likely to be a more stable mother. So we would be concerned if a mother isn't taking their OST, so their opiate substitute treatment as prescribed, because it can lead to withdrawal. If we have regular contact with pharmacies, this is really important, and it should be increased during pregnancy as well. So you should be calling kind of if you're in Turning Point, you should be calling every couple of weeks to your pharmacy. Each prescription, basically, we sent them out fortnightly to make sure they have been picking up and what their dose collections have been like, because there's the risk of withdrawals that we need to be making mothers aware of, but also it can suggest that they might be using on top of their medication. So if they're missing doses on those days, they're likely to be withdrawing, and then they're potentially using. So we want to be making sure that they are really aware that they need to be collecting every single day and not be missing doses. Every effort should be made to keep a mother on prescription. So if a woman misses 3 doses of her prescription, that means that she would have, we call it, you've fallen off script, and you would need to normally see a clinician to be put back on your prescription. However, we know that some women who are pregnant live very chaotic lives, and in these instances, we have a pregnancy keeping safe pathway. So this ensures that a prescription is always available at the pharmacy, and the decision can be made to continue dispensing even if the 3 doses have been missed. However, that's not the decision that the pharmacy makes. The pharmacy will contact Turning Point, and they will speak to the clinician involved and discuss the misses and just clarify, is it safe for them to continue to dispense, and we'll give them that advice. So that's just to make sure that a mother is missing minimum numbers of doses to try and sort of support the stability of the baby. Detox from opiate substitute treatment, as I said before, would only be considered during the 2nd trimester because of the risks in the other trimesters. And it's just really important that we are monitoring for any signs of withdrawal if they do carry out a dose reduction. Sometimes women will try and ride it out because they think they see themselves as a failure, that they've had a dose reduction and actually they've not been successful. But it's reminding them that that stability is the most important thing for their baby. And also, if they are withdrawing, the baby is going into distress, and it's absolutely not a failure. We would just rather them be on a good, stable dose to reduce that risk of going back into any illicit use.
We often find some reluctance, Fran, for women going to who need their dose increasing.
Yeah.
We find a lot of reluctance, and a lot of women really want to reduce their amounts by the time the baby is coming, but we would not recommend that really, because
No.
as you say, it's that risk of instability at the crucial times. So
yeah, and
yeah,
also
we
the
would-
likelihood is in that 2nd trimester, because of the rate that we have to reduce at, they're not going to be off of their methadone by the 3rd trimester. So it's almost looking at actually what is the reason for this reduction, because often in the final trimester they will often experience a decrease in stability on their opiate substitute treatment, and it's common to need to increase the dose, and that's because of increased metabolism. It's nothing to do with the woman, the way she is feeling about her substance use, anything like that. It's purely pregnancy related, and it's about the increased metabolism and in the increase in blood flow. So as Sarah said, actually women can sometimes be worried about increasing their dose, and it's offering that reassurance that it's really normal, and actually we want you to be stable, and it's not a failure, and it's not a reflection of your commitment or anything like that. And that's the reason then as well, when we talk about going down in the 2nd trimester, actually you're unlikely to be off of your dose by the 3rd trimester, and actually you're probably going to need to increase anyway. So we just want you to kind of try and remain stable, basically. There are exceptions where a woman might be on a very low dose of methadone, so she might be coming to the end of treatment, she's become pregnant, and actually in that 2nd trimester we could get her off of her methadone. And
it's rare though, isn't it?
yeah, very rare.
It's very rare.
think I've had one case of that in the
Yeah.
entire time I've been working in substance misuse
And I think
services.
it's worth pointing out, yeah, so when a woman gets pregnant, the blood volume increases by 50%. It's called hemodilution. So it's likely that the methadone requirements, you know, will go up for some women. As you say, it's to do with metabolism and that as well. So yeah, it's just about convincing them actually that it's not because they're not doing very well that they need the increase. It's
Yeah.
to really keep them stable to accommodate the pregnancy within that plan.
Yeah, and we do know a lot of women will be wanting to get off of their dose because they're worried about neonatal abstinence syndrome as well after the baby's born. So we know that OST can cause some issues around that. However, there's no evidence to suggest it's dose dependent, and kind of we just want to keep them stable basically. And any decisions around their OST should always be made in consultation with their prescriber at turning point. So if you're from another agency, it's really important that you're getting in touch and that you're speaking with a prescriber about anything that a woman might be telling you, because sometimes in pregnancy, if they're stable, they will have their doses to take home. And they might take it upon themselves to think, oh, well, actually, you're not going to reduce me, but I'm going to do that myself, which can then put the baby at risk. So if you hear of anything like that from a mother, or you have any worries, please speak to us and let us know, because it's important that we're aware to be able to sort of make any necessary changes to that prescription. And we can also, if needed, we had a lady who was doing that recently, who was self-reducing her Esprinor dose, and we were able to recognize that with the support of the specialist midwives and change her pickups of her collections, so we can actually have them on daily supervised at the pharmacy, so we know that they're taking their doses properly.
Yeah, the service user will be focused on reducing or stopping OST use altogether, but what they're not realizing is they're exposing themselves to actually becoming coming to the point where they actually may feel the need to use drugs again, and then that is obviously reintroducing the whole risk and starting all over again, and setting themselves up to fail, to be honest.
I'm not sure who I was passing on to on this one. I mean, I can carry on if needed.
Sarah, I think, was going on to do 19. You're on 18.
Oh, okay. Well, this is me, and it's 19. Thank you. Okay. So the other the kind of the other part of treatment is detoxification and stabilization that we offer. So quite frequently we find that women will benefit from a period of stabilization in an inpatient detox facility. So that's things where we find that women might be continuing to put their baby at risk with their substance use. So they might be using crack, heroin, or alcohol. Often, well, but with the crack and the heroin, it's about stabilization, but with the alcohol, it would be about detoxification off of the alcohol to cease the use. And then with the crack, because as Ange said, you can stop crack use and it wouldn't have an impact on the baby. It's just about making mum comfortable with different medications whilst she's sort of an inpatient, to give the baby a break from the crack use, in the hope that then that will allow mum to maintain her abstinence once she leaves the inpatient facility. And then with heroin, it's about ceasing that, but then it also allows the titration on the opiate substitute medication to increase at a more rapid rate. You're under much more intense supervision, observation, and we can get mum on a dose that is that's got her stable, whereas sometimes women in the community find that titration quite difficult and don't necessarily get on what we would call a therapeutic dose. So there's lots of different ways we can do it, but those stabilization and detoxes are a really important part of our treatment. So we use an agency called The Level, and they are based in Nottingham. So once the necessary paperwork is completed with a woman, the pregnant women are given a priority placement at the detox. So the paperwork we normally complete, if it was for a service user who wasn't pregnant, they would be expected to complete that paperwork alongside their worker, and they are expected to provide a signature basically. And it's about motivation to go into the detox and support them sort of in being more successful, because they're part of that kind of application process. However, with our pregnant women, we know that that process with some of our more chaotic sort of clients who are sort of, you know, often they might be homeless, sex working, and have really challenging situations, to expect them to come in, complete that paperwork and sign it is a barrier to them being able to go to detox in a timely manner. So what we will normally do is do the paperwork with them in their absence, paperwork for them in their absence. It will be sent to the detox and we will get a priority placement. And even if that paperwork isn't signed until the day they go into that detox, until they get there, that's absolutely fine, because we don't want a barrier and we want to get them in there as quickly as we possibly can. So it's really important that we take a multi-agency approach to detox planning. If there are other agencies involved, what I like to see happen as best practice is that you call a professionals meeting to make sure that everybody knows what that part in their detox is. It isn't just Turning Point's responsibility. Everybody's got a part to play in making sure that the detox is successful, that there's a real clear safety plan in place for that woman's admission, the detox, and then the discharge, because we want to give that woman the best chance when she comes out of that detox to stay abstinent as well. So we should be thinking about, within that safety plan, the suitability of the accommodation that that woman is potentially going back to, and the management of any situations that put them at a high risk of relapse. We should also be completing, so this is a Turning Point work that we do, pre-detox preparation work with the woman where possible, to again put them in the best possible position to make the detox a success. So that might be things around like looking at relapse prevention techniques. Let's look at your high risk situations. What plans are we putting in place to reduce the risk of that? What's detox going to be like as well? What can you expect when you're there? Because sometimes women will leave detox early because it's not how they expected it to be, and they're not coping in that environment where they're sort of, I suppose, contained in a way, and it can be quite triggering for a lot of women to be in that environment. So making sure you do that pre-detox preparation work is absolutely essential.
Can I just add, Fran, as well?
Yep.
It's really important that Angela and I know about, you know, when people are going into detox as well. So if it's a last minute thing, like, you know, make sure that we know, because one, we can actually go and visit them in there and do an antenatal check and provide extra support. Two, we'll know when they're coming out. And again, we're that extra arm of support. So it'll be, you know, be good if we could have that information, because we don't always get it.
Yeah, absolutely. I mean, it should be a planned approach. We shouldn't just be, you know, it should be a multi-agency planned approach. It's never sort of with a day's notice. It's kind of, we've always got at least a week's notice, haven't we? So we should be able to do that. Okay, who am I handing over to? Is it Ange?
Yeah, so we know that substance misuse can harm a baby's development once born as well, because the impact of parenting capacity. So babies that don't receive the right attention at the right time, mum's not responding to feeding cues because she's out of it. Babies are allowed to stay with the mums, and you do find that once the baby's been born and the mum has the baby in her arms, it all becomes very, very real. And, you know, there's all sorts of feelings of guilt and shame attached with that as well, once they're looking into the baby's eyes, and they've got to deal with all that as well, which can actually provoke more use. And we often have mums going off the unit to use, then coming back to their babies to look after them and provide care, which is not good, but we don't always know that they're doing it. We also have a parenting log where the staff, as closely as possible, monitor how the mum is responding to baby's needs. We often end up having to take care of the babies because of mums falling asleep whilst feeding. As we know, that's precursor to SIDS, and also the increased risk of SIDS because of the cigarette or the remnants of anything else they've smoked on their skin, that can pass on to the baby also. And that lack of emotional warmth and bonding, that can affect a baby from a very, very early stage. So that's a massive impact. And as I just said, parents that don't always understand the impact of their substance misuse has on their babies and their children. But it's only when the baby is in their arms looking at them that they will sort of start to realise. But by that time, often it's too late. A lot of our women, as soon as the baby's born, after the 72 hours has passed that we usually keep them in for monitoring, a lot of the mothers abscond from the unit and leave their baby behind. Invariably, they do come back to visit their baby, but a lot of the time it's too painful, so they won't come back, and the baby's just left, either on the neonatal unit or on the ward. Others, we have to deal with that separation. So social care will come if there's a plan in place, and mum will know about it, and it's up to her whether she stays for it or not. Sometimes she'll want us to hand the baby over. Other times we're just there with her while social care take their baby, and then often she will go out and do anything she can to get out of the mindset that she's in, which includes using these substances. Most mums want to go to have contact with their baby. That usually is arranged after they've left. You can often find as well that I'm definitely not using anymore. I'm going to be on a methadone program, and I'm not using any more substances, and I'm doing really well. I'm attending all the contact sessions that have been set up. They're very emotional, heartbroken, in fact. There's a lot of judgmental behaviours surrounding that. Well, if you feel like that, why don't you just stop taking drugs? We even have that in the hospital, believe it or not. And it's really out of order, and we try and stamp that attitude out. It's not helpful in any way. So yeah, it's about supporting the mum after the birth as well, keeping her safe on a dose of therapy, just so that she can actually have the contact with that baby. And some women do go on to actually do well and do stop using drugs, become stable, can have more and more contact. A lot don't manage to get their babies back, but some do. We've got one service user that went home actually who still used heroin. We couldn't believe that she went home, but she did. And actually now she is just stable on methadone, because she realised once she'd got her baby that, I can't, it's that real. And she had other children too, that she actually did, get stable on it. So every single little bit of input that we have is very, very important together as a team. I mean, it's important that we give parents relevant advice to prepare for their baby's arrival. That includes, even if we know that social care have, if they have an option, they have a plan to take the baby into foster care, it's still important for that woman to be fully prepared for birth, be prepared for the baby's arrival. They will still need baby items and clothing. They are going to look after their baby for the first 3 days. That may well go on. Babies also take things with them to the foster carers, and the parents will then provide care, might even bath the baby or dress the baby, there and then. And it's also important for their mental health, so that when they look back, it's not creating as much trauma around that scenario as it would as if they had no preparation and nothing. They've actually done something for their baby. So, for example, recently there was a mother that knew that a baby was going to be taken into care, but I just went to the ward and facilitated her bathing her baby. because that was probably going to be the only time that she would have that. That's a memory that she can keep. Took photos for her as well. And I think it had a big impact. So it's about, you know, whatever anybody finds or thinks, they're still a mum, and we don't want to create more trauma. We want to help to prevent it.
And
So,
just to
yeah.
mention on the it said we're talking about the advice and support for preparing for baby's arrival as well. If you are working within Turning Point, we have the pregnancy guidelines, and within there are some worksheets that you can complete as part of your sessions, because it's really important that we make sure that that person has a sufficient support network, because often babies do go home and actually it's really challenging, isn't it? We know going home with a baby is really challenging, but actually if you have substance misuse issues as well, that makes the situation even more challenging. So we need to make sure that there is a support network in place, but also safety factors for the baby and safety planning. So we have those conversations like, okay, you're doing really well, you're not using, but if you were to relapse, let's make a plan for what you would do to make sure that your baby is safe. So who would you be contacting? What actions would you be taking? Things like that.
Oh, this one's a big one. So Angela and myself and another colleague, Gina, we're training currently to be able to administer the implant. Currently, maternity can prescribe contraception before even the woman leaves hospital after birth. So at cesarean section, they can have the Mirena inserted. They can have the implant, they can have the depot, and they can have the pill prescribed. Also the copper coil, the coil that can have a section as well. So that is a really, we want to make that as part of the postnatal discharge, and also would like to create a system where this is our intentions for future planning, where you know, women are recalled for contraception, whether it's via the GP, whether it's in conjunction with us. As people are women are recalled for the smear test, we want that to be for contraception as well. And it's really crucial. So some of the women that we look after that are substance misusers and street workers, they go straight out street working, and you know, we know that you can get pregnant very quickly after you've had a baby. They're all unwanted pregnancies to an extent. As I said earlier, one of our women delivered last year in December and has now just delivered again prematurely. We did give her contraception, but then she didn't go for the next bit. So it's just it's about keeping up with that, and it's really important to discuss contraception all the way through the pregnancy. Really, have you had a thought about this? Have you considered yet what you're going to do after you've had the baby? It's a good idea to think now so that we can get the plan put in place, and you could liaise with us over that as well about contraception, and we can get that put in place at the hospital.
And I think as well, one of the things that we often struggle with is women will often leave the hospital really quickly, won't they? Like you say, and then they don't have any contraception, and then they never come back. Is something that we find quite challenging, and that's where I think often our role comes in having these discussions, and also other agencies like health visiting, social workers that do still manage to have that contact with those women, to use every opportunity to discuss those things, to remind them that they are incredibly fertile at that point after giving birth, exploring their options for them. But sometimes with our women, especially at this point when they've, you know, been through the trauma potentially of having their child removed, is a bit of hand holding, like support them to book that appointment, take them,
book it
you know,
for them.
Go, you
book
know,
it at the
I'll
GP
come and
for
meet
them.
you, and we have done that quite a lot recently, because it's the importance of it. It's just so profound. We've seen a massive increase in women who use substances having babies, and really risky women as well. We've seen in the last probably 3-4 years the increase in very, very risky women having babies, and every time they go through a pregnancy like this, there's a massive danger to their life and another baby that is born with significant issues. So
And into care.
yeah, so whatever we can do to support that woman, because often they do, when you speak to them, they absolutely do want contraception, but their lives don't necessarily allow them to easily go about, for you or I, it might be like, actually, do you know what, I book an appointment and it's really easy for me to keep that, but it's not that straightforward for a woman who uses substances, and there shouldn't be any judgment around that, but it's just what we can do to support them, and making sure that we are taking into account their sort of views as well and what they want, and not sort of taking that away from them as well.
Yeah, definitely. Okay. It's not often that women that do take Class A drugs go home with their babies anyway. There's all the guilt surrounding that, and all trying to get their baby back, and it's not often successful either if they've already gone down that route. However, mothers that have been using cannabis and alcohol seem to get away with it a bit, a bit more relatively, excessively. I mean, most of them go home with their baby, which is unfair. But it's very difficult. I think cannabis is more widely accepted, where it's still a Class B illegal drug, and with all those effects, I don't actually think that. I think that should be made. Anyway, I won't tell you my opinion. So a baby can be experiencing withdrawals as well from cannabis. So might be going home with mum, experiencing withdrawals, can cause distress for the parents, but very often the mother will not agree that the baby is experiencing withdrawal symptoms, and that can lead to a barrier to care where mum might not get the right help for baby. So cannabis is as important as the Class A's really, and so is alcohol, and we know that there's a massive increased risk of SIDS with both of those. So yeah, we need to keep our eye on that, and otherwise as well, mothers can become really run down. Their immunity, their hormone levels are dropping. They've got the stress of the baby, which is likely to increase their substance misuse. But also out of tiredness, hopefully you're hoping that it decreases it in the same vein. We can introduce educational sort of tools to help the mums to recognise NAS for their baby so they can get help. It's really important to speak about all that and how to comfort babies. The babies usually need to be held quite firmly, and often a dummy can really help soothe the baby. I think that the women that are coming back to you after they've had a baby who have not taken their baby home, it's still really, really crucial the work that you do afterwards, because that woman is likely to come back to us very soon as well. So it's about managing that risky behaviour, again, about the contraception, keeping the drugs as to use as a minimum, keeping them stable on the OST. It's really still important the work that you do. So I know lots of women go AWOL after they've had the baby, but it's really important to try and draw them back in as soon as possible.
Yeah. Sorry, I was just going to mention now about the VARM process as well, because that's something we've used quite a lot, and I know that you guys have as well, is that where we are worried about these women who are more like their mental health is more impacted, maybe they have more risk factors in their lives, that we are considering the VARM process, which is a vulnerable adult risk management meeting, to try and manage that risk around that individual as well, because it's sometimes it can feel like the woman has the baby is removed, and then the professional network is almost decimated, and that woman
we
loses
can
a hell
stay
of a lot of
around.
support.
We can stay around for up to 6 weeks. We never dump our women. We never discharge them unless they don't engage at all. Despite all of our best efforts, we can actually keep women on up to 6 weeks, even if it's just once a week or whatever they need. We will do that to support them, and, you know, hold their hand for a bit. We don't get to do that with a lot because they do just go. But we never just let them go. They let us go. And I think as well, during that VARM practice, I think that we could really push the contraception there, and all of the professionals on it can be pushing that, because we're seeing the same women coming back over and over and over, and actually their children are having babies now and their mother is pregnant again as well. So it's going on for years through the family. So it's really, really important that we really need to get onto the contraception as part of the care.
Oh,
Is this me, or
neonatal
is it- no.
no, it's me. Neonatal abstinence syndrome. Although if somebody starts crying, you might have to. So that's what we were describing earlier, is the withdrawal effects in babies, and we find that this can happen to babies that are using illicit substances, babies that are stable on mums using methadone. They can also have NAS, and we also have women that who are on medication for mental health issues that can show NAS symptoms as well. So it's important to understand what it is. It's just that medication that they're on, they're actually reducing off of, and the baby is reducing off of them. So we'll start to have those symptoms. The symptoms of NAS initially is sort of excessive sneezing, yawning and a stuffy nose, irritability, high-pitched cry, inability to settle. So they need quite a quiet, calm environment. Excessive sucking, which is why we recommend a dummy, and they can be quite poor feeders with regurgitation and vomiting. They can have loose stools, as Sarah said earlier, which means that they get quite sore and excoriated bottoms due to the acidity. They have quite rigid arms and legs, or their body, and they can be quite jittery, and they shake, and because of that they can have poor weight gain and weight loss just after birth. So they can often have more than 10% loss of their weight, which we need to monitor really carefully. We want to make sure that they can put on that weight, and that actually their jitteriness isn't excessive that they need taken into hospital. I have had probably a couple in my time in the last 14 years that have ended up being taken back into hospital with NAS withdrawal, because they are so jittery that they're not resting, and therefore their body is on the go constantly. And these babies are treated with Oromorph usually to try and settle them down in order for them to put on some weight and get that rest in between their feeds. As I said, they can have poor sleeping and increased wakefulness, rapid shallow breathing and respiratory depression, and a high heart rate. Sometimes they have instability in their temperature, which often leads to us doing septic screens on them. So mums and dads often say that this is because the baby's got an infection. It's an infection screen, and often those infection screens come back negative, but the mum still holds on to the fact that, you know, they've had an infection screen, so therefore it must be an infection. We will also start them off on antibiotics initially, because we don't really want to wait until that that result has come back in case it is a positive to infection, and then we've delayed treatment by 24 hours.
Yeah, so they do try to negate the responsibility. Anything that they can grab onto, so they will say, oh, it's because of baby's infection, nothing to do with the NAS, or, you know, that because of drug use or anything. So,
and it's really important we do try and get our our staff on the unit to identify that and to say it to them. They're not keen to say it to the patients, and I think that's just because they're a bit unscared of what they might do or what they might say. But I'm very clear, if I see a baby and it's jittery or it has any of these symptoms, that, you know, that is withdrawal. And like Sarah said earlier, stiffness in the limbs. Now, often it's kangaroo-ish, so they hold their limbs up tight. Other times it's where they hold their body so rigid and straight. That's quite a rarity, but it does actually happen.
I think the next slide's really been covered by what you've just said.
Okay.
There are some questions, I think, from Kelly and Buman, or are they legacy
Sure.
hands? Kelly, is that a legacy hand?
Sorry, that was taking me a little while to unmute there. It was just an ask, really. I was looking at arrival of baby. I'm newly appointed operational children's service manager, and we'll be opening a new family assessment home within Leicestershire. And I basically, it was an ask, really, just to be able to network with sort of Francesca and some of the other midwifery team or health visiting team that I've got are in the substance misuse team. Some of the mums that will come may well have just had their baby and be coming to the family assessment home for that assessment to find out whether or not they can keep baby. They may well also be pregnant. We will have babies or children up to 2 years. They may well be pregnant and using substances. So really, it was just an ask if you could sort of look at my details and possibly send me your email address.
We can
in
put
the
our email
chat.
addresses in the chat,
Yes,
so that
please.
everybody can have access
Absolutely.
to it. That would be helpful. Yeah,
So
no
that
problem.
would, especially sort of turning point as an organisation, if mums have got a plan, you know, a team around the family, or a plan, or it's child protection, or potentially looking at interim care order, you know, if we could work together, that would be really helpful for us.
Yeah, absolutely. That is, and it'd be really, really helpful for us to know that that process is going on with you as well.
Absolutely.
I think for all of us. So yeah, definitely. I've just put mine in the chat.
Thank you, Francesca. I particularly wanted to, well, all of the and the midwives. I have just done written a medication process and protocol, because some of our mums may be coming on a script. It's where we keep that medication. It's about keeping mum and baby safe. Looking at safe sleeping and SIDS and that sort of thing. So it'd be really, really helpful to work with health and third sector partners around the best outcome for mum and baby.
Yeah. Is there any more hands?
Yes, it's Buman.
Yep.
Buman.
Thank you so much. The only question I have basically is I'm thinking about my own consultations, and quite a number of times of the amount of women that don't attend their smear tests is quite staggering. And obviously, in terms of contraception advice, is there any other than just referring back to the GP? Is there any other services, particularly in the county, where I can refer them for their contraception?
Yeah, you can refer to the sexual health services in the Haymarket in Leicester.
Okay.
I don't know about the outlying places, but also if they are, you could actually make them an appointment at the GP surgery, either with the nurse or the GP surgery, and then, you know, tell them you've made their appointment. All they've got to do is turn up.
Yeah.
You'll kind of gauge who you can do that with and who you can't. Apart from that, it's very difficult because we can't enforce it, unfortunately. But also, if you're dealing with a pregnant service user and you're talking about contraception, you can always make them aware that can someone go on mute, please? You can also encourage them to you know, speak to us when they're in the hospital about contraception, because we can sort that from there.
Yeah, that's great. Thank you so much.
Sharon has a hands up.
Hi, yeah, it was a question earlier, you know, when you was talking about babies and their development. And I wondered, in terms of almost from the beginning when the woman becomes pregnant and the birth father is using drugs, whether or not there are any issues that the sperm might be not as good, I don't know,
Definitely.
quality or however. Do you see what I mean?
Yes,
So
I
you've
do.
got both parents using drugs, then you've got the
Yeah.
baby being conceived.
They always manage it, don't they? Yes, but yeah, drugs does affect the quality and amount of sperm. I don't know too much about it, but I do know that. But I think as well, where abnormalities are concerned and forming of the baby, I think that, yeah, if the father is damaged in any way himself from his own childhood, or you know, from his own growing in utero and then using drugs as well, that can have a massive impact as well on baby's development.
And there's also the impact that a father can have during the pregnancy as well.
Yeah.
So some of you may be aware of the research. So there was a paper around the myth of invisible men, which is definitely worth a read. Because often during a pregnancy, there is a lot of focus on the woman. And, you know, if a woman misses an antenatal appointment, you know, we put down those missed appointments, but actually there is never really much of a record or an onus on the father's attendance at those appointments. And actually, you know, we give women key messages, don't we, during the pregnancy that are relevant to the father as well, and they are often not getting those messages. And it's something within Turning Point we've tried to work on. Some of you may be aware of ICON, which is the about how to reduce the risk of abusive baby head traumas, and the message around that. And in Turning Point, where we have a father of a pregnant person, we also track them in the very same way that we would track a pregnant woman, and we ensure that they are getting the advice that they need throughout the pregnancy, because actually we might be the only people that they actually see. You know, they don't necessarily see the midwife, or, you know, they're not there when the social worker visits or whatever it is, and we need to do what we can to try and support the risk that potential that man might present. And there's also an increased risk. Domestic abuse goes up around 30% in pregnancy, so we need to be mindful of the risk of that as well, and what's going on in that relationship. And we do have quite a coordinated approach with partners as well, I think, between us and the midwives and social workers. And we have a pregnancy MDT that takes place where a woman is discussed once every trimester, where we have the presence of service manager from social care, the midwives, and then the Turning Point worker and myself. And we always invite the partner's key worker as well, so that there's that kind of holistic approach to risk management.
I think as well, it's really important to get the father, if possible, on side in the absence of domestic abuse. If that relationship is a positive one, the father of the baby can often facilitate the women's attendance, because he might be the only one that she trusts, and you know, she might be codependent on him, she might really listen to him. So it's really important. And we do have a few service users that are really encouraged by their partner, and he will keep track of her appointments if she's not good at doing that, and you know, make sure that she gets there. So yeah, that's a really good point.
Is that all the questions before we move on? I can't see because I was sharing my screen.
I just raised my hand just to back up really the key messages that you're putting on there, with regards to advice for men as well, and particularly men who have been using benzos. Like I said before, there's a piece of research that actually says it takes approximately 7 months for the risk of genotoxic effects, you know, like whereby the sperm itself actually contains the possible cleft lip that it can pass on to the newborn. So the contraceptive advice there would be for men to use contraception, and actually, perhaps would advise their partners as well to use contraception for that period, because it's quite a risky time. And this is advice from the Medicines Health Regulations Authority.
Thank you, Berman. Okay, who's doing the next slide? Breastfeeding one.
Sarah, can you do it for me, because I'm being
Yeah.
mauled.
Okay. So if we have a mother who's just given birth who is really stable on methadone, we would promote and encourage breastfeeding. As we know, it already encourages bonding and emotional attachment, regulates the baby's temperature, heart rate, blood sugars. There's all sorts of healthy bacteria and flora that is passed on from the mother to the baby, which will help the baby to help the baby's immune system. So we would want to promote that where possible. And I think it just promotes a more natural reduction in the methadone. Really, it helps the baby to we don't want, if the baby can withdraw from methadone, so we don't want just her to stop if she can just do it naturally, because only the small amount passes the breast milk, so that would be much kinder for the baby. However, if we know and we must test before we promote that the women have any other substances in their system, that we don't want the baby having that, because that will be increasing the risk of withdrawal even further for the baby and causing more and more problems, and it increases the risks of SIDS as well. So it said breastfeeding should be avoided, especially in the first 24 hours after use, if the mother's taken stimulant drugs, alcohol or high dose benzodiazepines. But I think it's very difficult to monitor that, especially if mum keeps going out of the unit, coming back. We're not there on the ward all the time. The staff do the parenting log, but they can't absolutely write down every second of what that mother is doing. So I think if there's any suspicion around taking the drugs, I don't think breastfeeding should be promoted, but I would definitely say so with methadone. Same with IV use, really. They're discouraged from breastfeeding. Advice should be sought of the safety of breastfeeding. I can't see that there is any safety really around breastfeeding.
It was around the BBVs. So if the mother has BBVs, that the advice should be sought around the safety.
Right, okay. Yeah, or if there's bleeding or cracked nipples as well, need to make sure that her status for hepatitis C or B as well is known, infectious diseases status as well, which we do find that in the beginning of pregnancy, but often if women are out IV using, sex working, if we're not testing that all the time, we don't actually know that at birth. So I think that's something to consider as well. We would encourage mums to breastfeed immediately before they have their OST dose, but yeah, it says if heroin's used, breastfeeding should be avoided for at least 24 hours after. That's only limited to 24 hours if you can be sure that the mother has not used again, after she's fed the baby. So it's really, really difficult one with breastfeeding. Yeah, after birth, a lot of mums that are sorry,
This
carry
one's
on.
for me.
Oh, is it?
Yeah,
I was
yeah.
just going to go with that. That just carried on from a breastfeeding.
So yeah, it's talking a bit more about opiate substitute treatment. So basically, after mums have their babies, we talked about the dose needing to be increased for a variety of reasons. However, they can actually start to report over sedation once the baby's born, and they'll need potentially their opiate substitute treatment to be reduced, because over sedation, as you can imagine, can impact on their parenting capacity, and it can also increase their risk of overdose as well. So it's really important that they are having an urgent kind of consultation with their prescriber after the birth to review their doses, especially if it's been increased.
The reason for that, Fran, is because of the hemodilution, isn't it? As the mum's body starts to return to normal, especially within the first 6 weeks after birth, their requirement for OST will probably greatly reduce.
Yeah. So, and that again is something with the mums that we need to be encouraging them to have that contact, and that's from every agency really. If you're going in and doing a home visit with a mum as a health visitor, an early help worker, a social worker, actually just having those conversations of how are you on your dose now you've had the baby, are you feeling more sedated from it, are you having any signs that maybe you do need the dose reducing, or actually some mums still feel perfectly stable on that dose. So it's completely individual, and we shouldn't expect a woman to reduce, but it's just knowing that the risk is there that they might need that reduction to happen. When women are going home, we need to be aware of any safety plans for the baby being discharged from hospital. And contact after this time needs to be consistent and regular, with home visits being completed at the earliest opportunity. Now, that's from every agency. This needs to be a multi-agency approach, because we know where a woman who uses substances goes home with the baby, there is a much increased risk to that baby's safety. We should be aiming to assess mum's bond with her baby as well, and offering support with being a new mum whilst being alert for any signs of relapse. It can be a really difficult time. A lot of our mums have underlying mental health issues. They might have a history of postnatal depression. Again, like I said earlier, having a baby is significantly stressful time, isn't it, going home in those first few weeks especially. But actually, if you're a mum with a substance misuse issue, that is even harder. And often our women, when they're stressed, their way of coping in the past might have been to use drugs. So they cope with stress by using drugs. So this is an increasingly stressful period. So we need to make sure that we've got safety plans in place there to support them to reduce that risk of relapse. Where a parent is prescribed opiate substitute treatment, safe storage must be discussed, and we must be ensuring that a lockbox is in place. And that's not just for their opiate substitute treatment. That might be any kind of drugs that they're using, any illicit drugs. It might be any prescribed medications from their GP, any paraphernalia. And we should also be talking about the safe storage of alcohol. So Turning Point will always do this. We do this within our key working appointments, and we do this in our clinical appointments. And we will always do a home visit to check that's in place. However, if you're from another agency, it doesn't hurt to have those discussions. Don't just take it for granted that Turning Point have done it. Make sure that that becomes part of your conversations. And if you're on a home visit, just say, can I have a look? Where's your box? Because sometimes as well, people they'll be storing it safely when we come to do our home visit, because they know that's what we're coming to look at. But actually it offers you an opportunity. They're not expecting you to talk about that side of things. So making sure that it is actually being stored safely can be really helpful. We also provide parents with the LSCPB Risks of Harm to Children in Your Home leaflet. But this isn't just for Turning Point to use. We use it an awful lot in our service, but actually it's for other agencies to be utilising as well. It's accessible via the LSCPB website, and it contains an absolute wealth of information that's really, really important when somebody has children in their home. We know that the risk of exposure to opiate substitute treatment for infants and children is really, really dangerous. And a few years ago, we had a baby sadly pass away from exposure to opiate substitute treatment. So it's really important that we're reiterating to parents that it is a significant risk. And things like dummy dipping is something that we would, it's massively dangerous. Don't do it, basically. But it's something in the past that you know, dipping a dummy in alcohol, in the OST, things like that, people thought that that was okay, but it's massively dangerous, because a dose for a baby is a tiny amount, can be toxic to them.
We have
And
had a
that's what
baby
we
that
need
was
to
given
know.
methadone by a mother and baby died.
Yeah, just mentioned that. And also we need to be advising them explicitly, and it might seem really obvious, don't give your baby methadone. Like Sarah just said, we did have the baby die. So it's important that you are that clear about it, because there is some level where, you know, you try and think about like the root cause of somebody giving their baby methadone. Babies are sometimes withdrawing when they go home. They still might be, you know, irritability and withdrawal signs can last for much longer. And a parent might think, oh, well, if I'm withdrawing, if I take methadone, I feel better. And actually then might think that that's the right thing to do for their baby to make them feel better, but actually we know that they are risking death with their baby, and it's absolutely not the right way to go. And it's the comfort methods that we should be going for those babies, and also seeking medical advice if they were ever worried about the severity of those withdrawals. I think that's on to somebody else now, is it?
Yeah,
Okay.
Sarah. Do you want to do sudden infant, or shall I?
You can.
Okay, no worries. So sudden infant death syndrome. We know for quite some time now that at least 4 babies die each week with no explained reason or cause. And there's a number of increased risk factors, which is significantly relevant to those who use substances. We know that low birth weight can contribute to babies having SIDS. These babies are 3 times more likely to suffer than the average term birth weight baby. We know babies that are in social deprivation areas are going to be at increased risk. We know that smoking, a third of deaths could be prevented if mums did stop smoking in pregnancy and reduce the smoking in and around them in the home and on their clothing. Substance misuse and domestic abuse also increases the risk. Babies who are born with NAS are more likely to have difficulty feeding, settling, which puts them also at an increased risk of being put in unsafe sleep situations, over swaddling, being put to sleep on cushions, sofas, chairs, leaving them in car seats. In years gone by, it was thought to be okay, but we now know that reduces the lung capacity because they are restricting their lungs so that they don't breathe deeply enough, and that can increase the risk of SIDS on children that have been left to sleep in car seats and play chairs. We know that bed sharing can also increase the risk where parents may be under the influence of substances or medication, or where bedding is unsuitable, and where they place them in when they are co-sleeping. So there's lots of reasons that can increase the risk of sudden infant death syndrome, and it's really important to give them that safe sleep advice and discuss with all families, regardless of their circumstances. It doesn't matter if they are a normal average woman who's coming in to have a baby, who's well educated. We do this for all mothers about safe sleeping. We follow the Lullaby Trust's guidance on sleep, and we encourage parents to read that as well. So it's really important that we identify the high risk groups, and we do tell them they shouldn't bed share, that it is increased risk of SIDS. It's important to explain why that's an increased risk, and it's important to make sure that babies are not overly wrapped, they're not over warm, that we take off hats in the home. Some people do still have hats on, so we make sure that, you know, as long as it's not a small baby, that they take off the hats, that they're in a comfortable environment, that they are placed in a separate sleeping arrangement. So it's
a Moses basket or a cot or a travel cot away from, so they don't get overheated, and that they are cared for in an appropriate environment when they are asleep. Is this mine as well? Yeah. How can professionals support expectant mothers who use substances? Well, I think the first thing we all have to be is non-judgmental. I mean, there is still a very big stigma around substance misuse, and I think even professionals can have their own views and opinions, but when we are caring for these women, we need to leave them at the door when we walk in, and we need to provide them with that non-judgmental, supportive, empathic and humanistic approach to their substance misuse. I often say, you've got a story, tell me about it. You know, I'm not judging you. I don't want you to judge me. You don't know my lifestyle, you know, my life events, but I do need to understand yours to be able to support you and give you the right professional help. So it's also really important to ask them how they feel about the pregnancy, explore their feelings around the pregnancy. Is it something they want to continue? Are they happy about it? Does it cause them anxiety? What are their concerns? We want to try and promote bonding with their baby, because if we can increase that bonding, the chances are we can improve their health and their health promotion and reduce any of the substances that they are taking. We want to try and ask them about names, how they feel about what sex of the baby, are they going to get the, you know, are they going to find out whether it's a boy or a girl or not, and how they are going to continue with who's going to support them, and generally show an interest in them and not just baby, because like Fran said earlier, you know, they often think once baby's here, everyone disappears and they're left, and that actually they only had loads of people because they were pregnant and they were having a baby. So it is a multi-agency approach at all times, and we all work very, very closely together, and it's important to work closely together so that we can try and engage those difficult women that really struggle with their substance misuse and actually are scared to engage with people, because it is around being scared. They're scared to address their substance issue. They're scared to reduce that because of the feelings and their thoughts when they aren't using substances. It might trigger thoughts from the past that is very difficult for them to deal with. And we all know that mental health services these days are quite limited. And often if we get them to stop substances, then we might heighten their mental health issues. So we need to be aware of that and have something in reserve to try and support them with that as well. It's important that, you know, we share information. I often tell them that we do share information and that we will be talking. You know, I have had people turn around and say, you can't, it's confidential information. Not if it's a risky, high safeguarding concern, it's not. And I try and explain to them that as well. So, and it's about trying to get them the best care. If I can get them seen sooner and get them on a prescription if need be, if I can get them back in to be seen by one of the prescribers to increase their methadone, or whatever their needs are, it's important to have that really good communication between everybody. So
I think as if they're stable as well, they're more likely to engage with us than not. So we want to promote that as much as possible.
Absolutely. And the last one for me.
Sorry, just the two bits about so there's the turning point pregnancy MDT that I mentioned before, and just mentioning that is open if it's relevant to your role. It's so, for example, social workers, even health visitors, once you've been allocated a case in that last trimester of pregnancy, please feel free and welcome to come to our pregnancy MDT, because it is really, really useful, and the sharing of information and getting that multi-agency approach and the kind of planning for birth and everything is just such an important thing. and about exploring their support network and offering them support if required as well. So if we have got, we might have a pregnant person, but their parents, their grandparents, or their partner are non-substance using and are involved, we have a family and carers service that they can actually be referred into, so that they can get the specific support that they need in order to, one, support them to cope, because it's quite a challenging situation to be in, but to also provide them with the knowledge and guidance that they can support and appropriately help that person as well.
Sorry.
No, this
So-
is just the last one, I think.
How can professionals continue to support? So ask about the father of the baby. It's really important to have that professional curiosity and be mindful of those risky men in the background. I mean, we know that domestic abuse can increase in pregnancy. We want to know who is around them, who they are getting their substances off, what risk those other people have to that mother and the baby. Be aware of disguised compliance and the possibility of underreporting of substances and falsified tests. We have had them. I've had women who've added their Subutex or buprenorphine to their urine. In our tests in the hospital, we look for metabolites. So we also look for the parent drug, which is the drug they use, but we also look for the metabolite. So for instance, methadone, we will look for methadone, but we will also want to ensure that EDDP is in, because that is the metabolite. So by identifying that there's both of these will mean that they are taking their medication. But if something's missing, then something's not right. They may not be taking their medication correctly, or they may be giving somebody else's urine and adding a bit of their methadone or their buprenorphine or something into their urine. So it's really important that we get proper testing and we get that compliance, and challenging those that aren't, which we've done recently on a couple of our women. So explore their preparation for baby, offer that support. We do have a charity called Baby Basics, which covers the whole of Leicester and Leicestershire, and any professional can refer to them. The professional who refers does have to go and collect the items and deliver it to the person, though. So it is something that's quite important. They do amazing bundles, and they really are so well used by our services. Act as an advocate, help their voice, get their views heard. If they aren't, when they go to conferences, if they're a bit unsure or a bit scared of saying things, you can actually advocate for them. It doesn't mean that you're putting your views across, you're just trying to help them with their views. Think about their feelings post-birth. So it's really important to congratulate them and visit them and share their, that they've got a beautiful baby, especially if that baby's going to be removed, because that increases the need for that emotional support. Only recently I went and visited a lady. The next day she just disappeared off the ward when she knew her baby would be removed, and the next day when I pitched up, she just broke down and sort of fell into my arms, and I just cuddled her, because actually that's all she needed. She just needed that emotional support at that moment. So it is important to try and help these women through these really difficult times, and post-birth, consider what support they might need going forward. And that's where some of the VARMs are really important, because they can then continue that VARM process and support that mum in moving forward. So I popped this up. So it's she is more than just an addict. She is someone's daughter, mother, sister, cousin, wife, or someone's friend. There isn't an addict alive that doesn't have someone that loves them, prays for them, so don't judge them.